afternoon, everyone. I'm Andrew, PGY2 here at Cottage. Cool, got it, yeah. So no financial disclosures. So something we all know and we always talk about in the ICU is ICU-acquired weakness. So some of the common features and the reasons we're always waking people up, coming off of sedation, is muscle wasting. Usually occurs in the first week. That's pretty significant. As well as a pathophys. It could be multifactorial, but as we all know, when people are critically ill, we want to move them around. It does affect approximately 40% of survivors. Some of the big things we want to talk about is the short-term versus the long-term outcomes. So higher rates of extubation failure and difficulty weaning when people aren't mobilized and aren't moving around. They last longer days on it, as well as longer ICU hospital stays. Some of the longer outcomes are increased mortality at 1 in 5 years, as well as the likelihood of being discharged. In another study I read, a lot of patients who were spent significantly longer time in the ICU actually ended up requiring SNF placement, as well as going to other locations. For recovery, the trajectory varies. Some patients fully recover, but as we've been kind of sticking with this and moving on with longer times, we've noticed that people suffer from these things. So early mobilization in the ICU. So what really is the definition of early mobilization? It's active exercise where patients assist with movement. It's not just us moving them around, or sometimes we'll do physical exams and they don't move, but actively getting them involved. In-bed exercises, standing, ambulation, and it really kind of involves our team, PT and OT getting involved as well. So the emergence of early mobilization, there has been quite a bit of studies, as we know. There was a landmark study that found that daily sedation, kind of what we were talking about in the previous slide, and interrupting that sedation is a big thing, as well as follow-up studies have showed benefits with spontaneous breathing trials, which, as we know, in our ICU, we tend to do daily if we can. So rising number of ICU survivors have led to recognition of long-term complications, so physical disability, as well as reduced quality of life in the future. So I know this slide has quite a bit on it, so we'll kind of work through it, but types of therapy. So if we're talking about PT and OT, so PT focusing on the physical mobility, OT is getting these patients to do kind of their daily task. Then adverse events. So a lot of times in moving these patients, we think that there's certain things that are going to happen. They're critically ill. It's a scary place, but there's less than 4% that are non-life threatening. So you see these transient desaturations, but they tend to come up. And then mobilizing patients, most of us are intubated in that area, or they have a trach, and actually those significantly rare, less than 0.05. So patient assessment and safety protocols. So on the table to the left, this was written in the early mobilization in the ICU in the chest journal. As you can see in the bottom 4, this is going to kind of segue our conversation. If you look above, about at the bottom 5 rows above, you can actually see where you see the green, right? That's going to go ahead and say safety criteria. So green is low risk of an adverse event, red is going to be high, and then yellow is kind of that median, just like a stoplight. If you look at the green ones, you'll see there femoral catheters, ECMO, and really the only contraindication was femoral sheaths. So importance of femoral catheters. All of us are trained and we're simply always using IJs. That's the first thing we all learned. But what's the reason and why do we use them? So if you look at the table to the left as I kind of work through it, so provide reliable central venous access for hemodynamic monitoring, as well as vasoactive medication, kind of equivalent to our central line. But really, if you look at the studies that have been done, it offers ease and speed of insertion, especially in emergency situations. If you look at the table, you see a 0.05 that was actually less than 0.05 that was seen with the speed, as well as the multiple attempts. I think that was kind of one thing that stood out to me. People that ended up having to attempt the right IJ ended up having to attempt the left as well, where on the FEM side that was significantly less. So between the speed and actual just being able to place effectively, it's pretty significant. Otherwise, it's beneficial for critically ill patients in that immediate intervention. So many times when patients are coding, you'll see some of our attendings or some of our senior residents placing these lines. So this beautiful building that we're all sitting in right here. So our current SBCH policy, speaking with our critical nursing staff, so right now, we absolutely do not do it. As you know, some of us have been on rounds and we're told that we have to remove that catheter before that patient can sit up or essentially start mobilizing. So kind of speaking with them and kind of getting a little more data on that, really, we encourage early removal. As we know, the location is a dirtier area and at times there is studies, but also some that have kind of said that the rate of infection may be equal or less, but we are worried about infection in that area, as well as the ability to maintain sterility and access as far as chair and mobilizing. If someone's sitting and you need to access that catheter site, it's much more difficult to attempt to move them to a bed and essentially do these things. But the big one in kind of talking to them and Dr. Fried as well. So it's the risk for hemorrhage. There seemed to have been a case in the past where a patient underwent cardiac catheterization, had a per-close device, and ended up hemorrhaging. But actually in that case, they didn't have an active line that was placed. So it wasn't as if they had a femoral arterial line or a central line that was oozing blood from the location. So the big thing is the risk, right? Why are people scared of these things? Why can't we do it? So vascular complications. So it can lead to minor bleeding, hematomas, but early embolization after cardiac cath has actually showed only 1.4% and 1.9% rebleeding incidence. For the infectious complications, as we were talking about, something that our hospital as well worries about, there's pretty low incidence of it. In a study that was reported, 3.7 incidence of catheter-related sepsis and 13.7 of colonization. The big thing that jumps out at everyone is these thrombotic complications, because there is studies that have shown it. It is a high risk of DVT. You're in the femoral region. And one study actually ended up showing a 34% incidence of lower extremity DVT. But we'll talk about this a little bit later as well. And then another thing is going to be these mechanical complications. So it's the femoral region. People are sitting up and moving. They're walking, bending at the hip. Can this become dislodged? So certain studies have shown ICU physical therapy actually found no related adverse effects, suggesting that proper protocols, if you have the right team, could possibly minimize these. So one of the big barriers, that's something that many ICU struggle with, is going to be that this requires an extensive amount of teamwork. You need to have PT, OT, nursing staff who is equipped and understands essentially the hemodynamic monitoring, as well as people who are in the room. So here we have our PT for mobility assistance. You need the RT for many of our patients who are intubated or trached, as well as you need an RN. Let's say you're going to go ahead and start CRRT. You need an RN who understands that as well for if a femoral catheter is placed for that. So one of the studies I saw from Tally et al. Outlined a safety protocol called ASK. Essentially assess, evaluate for appropriateness of early mobility, secure, essentially check the catheter prior to moving the patient, and then check for any type of kinks, because we still want to be safe and hemodynamically monitor our patients. So let's get into the big studies. So this here was a study that was done at Johns Hopkins. Essentially 101 patients that were prospectively collected and were seen. So they were seen here in the MICU. They were there for a total of 4 days, and there was no real significant difference in the type of catheter that was used, whether that was an arterial line, central line. We could see that there was no difference. Femoral catheters were more common that were arterial or dialysis catheters, though, however, in this specific study. So the big thing for these patients. So patients underwent 253 PT sessions over 209 days, and that was provided by 9 different physical therapists. And having those increased amount of physical therapists shows that it wasn't 1 or 2 that they could have possibly said that these 2 specifically understand this, as well as a median and mean session were approximately 1 to about 3 sessions, 2.5. The highest daily activity levels that we saw were walking at 23%, sitting at 27%, and ergonometry on a bike, where essentially you lay back and you pedal, bending at the hip and flexing, was approximately 12%, and just standard in-bed exercises of 38%. If you can see in the table, it's a little tough to see, but all of those nice zeros, that essentially tells us that there was 0 events of this. There was no premature PT sessions that were stopped due to the femoral catheters. And one thing I wanted to really highlight was that active monitoring was ensured in the waveform of femoral catheters during these therapies. So really, these patients were mobilized, and you could still hemodynamically monitor them, which is extremely effective in what we want to do. So to summarize that, there was no potential femoral catheter-related events in all 253 sessions, yielding approximately an event rate of 0%. So this, if you remember in the previous slide, we talked about that extensive incidence of DVT of about 34%. So this was a great case series, mobilization with femoral catheters in the burn intensive care unit. So for this, there was 13 patients, low population size, but quite a bit of femoral catheter usage. Many of them had placed CV and femoral cath. Some of them had it bilaterally and kind of researching it. So over 55 were placed. You can see that there was quite a bit of therapy sessions, over 417. And if you look at the type of exercises, pretty diverse exercising, sitting at the table, standing, active chair transfers, and even some were able to ambulate, which is extensive because these are burn patients. And as we know, we don't have a burn unit here, but that required quite a bit of monitoring. No catheter-related complications were found in those. And in the risk for DVT, as we know, these patients are actually quite hypercoagulable when they're in the burn state. So to see these patients essentially have no problems, not throw any DVTs during this study is something that kind of stood out quite a bit as well. So This was a great study here, feasibility and safety during CRRT. So this is something that we end up doing here at the hospital, and many times these are some of our sickest patients. As you know, we'll call our attendings in the middle of the night to get some of these things started, and this is the things we're most worried about. So here we had a prospective study of patients who underwent CRRT over 13 months. There was 268 therapy sessions, 57 patients, and 11 physical therapists. So still diversifying, including multiple types of people who can help with these problems. 29 underwent bed exercises. We had a supine cervical onometry, 30% sitting at the edge of the bed, which is hopefully what we can start doing here. And if in this data, the conclusion that there was no CRRT safety events, 0% occurrence in the group with femoral catheters. So adding on to that, you can see that these patients, quite a bit of data, were able to actually sit, move, and walk around while undergoing CRRT. So to add on to that, is actually mobilizing these patients going to help them during CRRT and improve filter life. So this was a study done, early mobilization of CRRTs. It's safe and may improve. This was done in Australia with 33 patients who were undergoing CRRT. So we had a mean half-life of the filter in the machine. Sometimes, you know, those things can clog, and we'll put heparin in them, of approximately 19.5 hours. There was no difference between the femoral and non-femoral filters, and filters lasted approximately 17 hours after intervention, intervention meaning walking or moving. So intervention filters actually ended up lasting longer than the non-intervention filters, and you can see that there in the 95% confidence interval with a p-value of 0.003. The femoral filter subgroup showed a difference, but the non-femoral axis filter group did not. As well as adding on to that in their conclusions as well, no episodes of filter occlusion or failure occurred during any of the interventions and no adverse events. So one of the big things, so ECMO, something we don't do here, but we do talk about, these are larger catheters with higher flow. You know, objectively we would say that this is, if anything, sounds more scary in the realm of moving patients with these ECMO catheters. This was an awesome study, kind of found when I was looking around. You can see in that picture on the left, that's actually a patient on ECMO who's actively undergoing it, walking around. So for this, out of bed, so patient's time of cannulation when ECMO was started, out of bed was approximately 3 days, and they were ambulating at approximately 4 days. Ambulation times by intubation status, when they were extubated, it was approximately 4 days. Intubated patients ended up starting at 5 days. So really, the ECMO speed and flow remained stable before, during, and after ambulation. So there was no events where if a patient walked with ECMO ended up coming back, was there any type of safety events? So distance walk during these days. So these aren't patients who aren't just sitting in bed, they're not just moving, they're not just bending at the hip. In the first day, some of these patients were able to walk approximately 300 feet, as well as on the last day, still able to hit that target rate of 300 feet. So it's not necessarily telling us in the data that they were only able to walk 20 feet at the beginning. They're actually able to maintain these things from the beginning. Complications, and you can see on the table, so no accidental decannulations or major bleeds were noticed, and like we said, larger catheter size, higher flow, some minor bleeding events, so 3 patients around the cannula site, which we can either throw an extra stitch or look, and there was 1 patient with distal perfusion cannula that was removed with recurrent minor bleeding, but still had distal pulses, so it was not a significant adverse effect. Patients also are ambulating for 34 days while they were undergoing these treatments, experienced recurrent minor bleeding, but that's quite a significant amount of days. And here we have a video that actually shows a patient undergoing ECMO and is actually bending at the waist and mobilizing.
Femoral ECMO, VV ECMO, and I put her on this exercise table, and with a lot of help from the perfusionist team and also the physicians, they were able to determine how much she could bend without impacting the flow. And we were doing like, this is the leg press exercise, just like when you go to the gym.
Yeah, so based off that video, we can see that patients with these large bore ECMO are actually still able to bend at the waist. And then these are my references.
Does anybody have any comments or questions?
Has anyone studied the preparedness of the ICU nurses versus your nurses at these huge academic centers that are doing this all the time? Like, I mean, I would think that that's probably the barrier, right? Is like how well trained are the staff at doing this?
And I agree, that's one of the barriers. A major barrier is education, nursing education, and education of the ancillary therapists, the respiratory therapists, and the physical therapists. if you wanted to say anything, but you want me to, okay. I can tell you that, that's always a barrier when you're doing anything new. And we, at this hospital, we tried to do some early mobility years ago and did educate the nursing staff. And we were ambulating patients that were on ventilators, right? Clearly, they were very educated before we started that attempt. And that's part of any new process. And I agree, they're not trained to do these things right now. That doesn't mean they couldn't be. The problem is that we get a lot of resistance from them because they think it's not safe. Okay, and that's one of the reasons for doing this presentation, is to convince people that it can be safe if it's done properly. And I think that that's true of a lot of things. Proning is another example. Proning years ago, when it came out, we wanted to start doing it, and the nurses were wigging out, and other people were wigging out also. And it took a very extensive educational effort on how to do that properly, to the point where we became, during COVID, we were expert proners, and we were teaching other facilities how to do this. Okay, so you got to start somewhere, and yes, they need to be educated. They need to learn how to do it safely. There's enough literature out there, there's enough people out there that are doing it safely that we could get their advice to help create that kind of a program. But I think even without major, that's talking about mobility, like getting them out of bed and walking them on ventilators with femoral lines and things like that. But just sitting them up in bed, is probably safe. And right now, the way it is, most nurses think that it's not. And there's a lot of resistance to sitting patients up either on the side of the bed or getting them up to a chair when they have a femoral line. And I think we can probably do that safely with very little additional education. But that's a great question. Yeah.
I hope I don't influence the vote too much here, but do you have a plan to change the education or policy here? After all this
Yeah, so hopefully in talking with our nursing supervisors, actually we were the ones in the ICU who gave me some of the data on the reasons why they actually have those policies. I don't think it hurt to give them a presentation like this and talk to them and show them the numbers and the data and the comfort levels we have. I don't know if you have
No, I think that this presentation is a really good start to trying to convince people that we should be able to do this and probably should be doing it. I don't know how you feel about it, or some of the other there any other intensivists. Dr. Sager still here? No.
Is the nursing literature different than, this is, I see.
It's actually not, because
Okay.
one of the, well, you can address the article that, so we did address this with the current critical care CNS. And she sent an article to us, in addition to making some comments, which he actually mentioned during the presentation. She sent an article to us that was from a critical care nursing journal, the ACCN journal. And it was on specifically femoral catheters with mobilization. And it clearly was I thought, very pro doing this. So I think, yes, there is at least some nursing literature supporting it, and clearly at all these various hospitals that are doing it, it's nurses that are doing it. The doctors aren't doing this, right? It's the nurses, the physical therapists, the respiratory therapists. Okay. Anybody else? Yeah.
Do we actually have a significant number of people with femoral catheters now? Because I know you've pushed hard to stay away from the femoral area.
Yeah, well, like that Andrew presented, that we have preferentially used IJ catheters for years, since we've been using ultrasound, because it's probably safer, although you can use it for femoral, so it's just as safe for femoral. There's always been some concern about infection risk with femoral catheters. The literature, I think, is conflicting on that, and there are actually some studies that show there's no difference. But even if there is a little bit of an increase, we've kind of stayed away from it because of that. I think the other reason why we stayed away from it is because once you put one in, that patient's going to be laying supine the whole time they have that catheter in because of this problem with not wanting to sit people up or mobilize them. And so that's also always been a consideration of why we haven't done more femoral lines. So I think that other than like in crash situations or when you don't have a choice. So I think if this would be part of the process, would be, part of that would be, the understanding that we would be able to mobilize these patients would probably encourage the use of those in more situations. I still would prefer probably the IJ in most circumstances, but I think that it would open up some possibilities. Any other? All right, well, it's time to vote. It is not safe to sit or mobilize patients with femoral catheters. How many think that this is confirmed? This is true? How many think it's plausible? Maybe we shouldn't do it? How many think this is busted? That looks like everybody. All right. All right, we're busted.